Look at the size of this beauty. Look at that. Look at all of that resorption, apical resorption there. Look at the size of this thing. This patient was referred to me for evaluation of teeth number 7, 9, and 10. According to the patient, the root canals were done approximately 20 years ago. Patient says she has had no symptoms with the teeth other than sometimes she can taste and smell something foul in her mouth. And finally, after years of experiencing the foul odor and smell and taste in her mouth, she went and saw her dentist, and her dentist took some x-rays and referred her to me. So this is tooth number 7. Take a look here. Look at this huge, enormous periapical lucency. So she has had this infection for many years, as you can see. And because she never went in to have frequent evaluations, at least, twice a year by her dentist, this went unnoticed. Look at that. Okay, so that's tooth number 7. That's tooth number 9. Okay, number 9 is okay, but number 10, take a look at tooth number 10. There's a periapical lucency there. All right, so we went ahead and discussed options with the patient. So number 9 doesn't need endodontic retreatment. It looks fine. But number 10 definitely, and of course number 7. So we discussed options with the patient. Patient says she wanted to try to see if teeth number 7 and number 10 could be saved. So as you know, I never go straight to an apical. I always try the non-surgical retreatment first, prepare the tooth for an apical by placing an MTA plug there, and then have the patient come back in a few months. If I don't see any resolution, any healing here, then the tooth is ready for apical because I placed, as I said, an MTA plug there. So apical is much, much easier and faster. And then also I've treated or retreated the entire length of the root canal. So if I went in straight to apical and didn't redo the root canal here, I would have left all kinds of bacteria and their byproducts here. So apical only addresses the apical few millimeters of the root of the canal, and if there is still bacteria here, which definitely are, then the seal, that your apical seal over time will break and the lesion and symptoms will come back. So you always want to redo the root canal first. So you disinfect the entire length of the root canal, recall the patient in a few months. If there is no healing, then you can go to apical. All right, so take a look here. So this was another plastic thermofill carrier. So remember how many of them I've removed in the past few months, and the other day I removed these. These were the predecessors to these. So when thermofills first came out, they had metal cores, and then later they switched to plastic. So this is what I removed out of the canal. All right, and of course irrigated copiously with full strength sodium hypochlorite, activated sonically and ultrasonically, and then obturated with white MTA. This is white MTA followed by gutta perchance sealer, and temporize the tooth and refer the patient back to her dentist. Patient will come back in a week or two so we can work on tooth number 7. I'm sorry, tooth number 10. We need to redo the root canal on that. We took care of tooth number 7 today, and this was a 1 appointment endodontic retreatment. And the reason I could do it in 1 appointment is because I tested the canal right before obturation by placing sterile paper point to working length, and there was no discharge, there was no oozing or anything, so I could obturate the canal. I placed an MTA plug, got a per-chance sealer. Look at this beauty. Huge periapical relucency there. Looks like tooth has a temporary bridge on it. All right, so take a look here. This patient was referred to me for endodontic treatment on tooth number 31. You can see that there's been a food pocket here, collecting food, microorganisms. Number 31, look at tooth number 30, recurrent decay there too. So looking at this tooth, this is root decay now. Subgingival decay, take a look here. Number 30, number 31. Like, so much of the tooth is missing. Yeah. Unfortunately, patient will have to take this one out. By the time I clean out all the decay, it'll be subosseous. So, yeah. Okay. Yeah, I was gonna see how old this patient was, but patient was in late 70s, so extraction. This patient was referred to me for endodontic treatment of tooth number 30. Patient's chief complaint is pain to biting. So just looking at the tooth radiographically, starting from up here, so you can see there is bone destruction right here. If you extrapolate from the mesial of the tooth and go here, you can see how much bone destruction this patient has had in the distal of the tooth, and to some degree, of course, on the mesial of the tooth, periapical lucency here and here. So when I examined the tooth, there was a crack, a fracture line on the occlusal surface of the tooth, the entire occlusal surface of the tooth, extending on the mesial wall, and on this side extending onto the distal wall. So let's go ahead and look at the video, and you can see what else I found clinically. Okay. This is basically a split tooth. You can see the fracture line here, and covers all the occlusal surface of the tooth. Goes on the mesial wall that way, and then on the distal wall this way. There is a buccal swelling associated with the tooth, and if I go in and take a measurement here, and this falls right in, as you can see right here, to 6-7 millimeters. All right,